Welcome to The Backstory with Dr. Ricky Singh. This podcast is focused on bringing you the latest research-based information about dramatically improving health, well-being, and quality of life. And here's your host, Dr. Ricky Singh.
Welcome to The Backstory. Typically we have a guest on the podcast focusing on a health and wellness topic, but I think today we're going to take a little departure from that norm and focus on my interest in health and wellness and who I am as a practitioner and how I got interested in this specific part of medicine. So I wanted you, the listeners, to learn a little bit about me and share with you what I've learned throughout this process and what I can do to provide you with future episodes and more education going forward.
Yes, because I would like to learn a little bit about you more than I do just from listening to the podcast. This is Scott Fitzgerald. I'm the announcer guy that starts at the beginning of the podcast and then ends the podcast and says subscribe and do all those nice things to help us along the road here. But I appreciate you'd let me turn the tables on you because you always do so much to talk about your guest. You're so generous with giving them the time to explain who they are and what their backstory is. But I think a lot of folks would like to know more about yours. So let's start. Ricky Singh, what is your backstory? What is your upbringing?
It's interesting. I always, I agree with you. I do like to highlight my guests who are the experts on the topics that we bring, but you're also right. Maybe a lot of the listeners don't know who I am and what inspires me. So a little bit about me. I'm from St. Louis, Missouri, born and raised. My parents came from India, so I'm a first generation here. And after high school, moved to the East Coast and have been on the East Coast since then. My dad is a physician. He's an internal medicine physician with expertise in cardiology and critical care. And my mom is a stay-at-home mother who largely took care of us. She was responsible for my cultural and religious upbringing and was very inspirational, probably on how I treat patients and how I respond to them. So both of them were integral in who I am as a person and who I have developed into as a physician. The field of physiatry is not well known. And I think that's one of the other reasons I decided to explore this media to share with the listeners on physiatry.
I had to look it up. I had to look up physiatry. It's like, okay, I still don't know what it means. So Ricky, help me out.
So physiatry basically is a specialty also known as physical medicine and rehabilitation. It really gained more traction after World War I and World War II, when a lot of the soldiers and vets came back with traumatic brain injuries, with amputations, and they needed a physician to take care of those needs. And that's how the field of physiatry really gained some popularity. But it wasn't until probably 20, 30 years ago when the traumatic brain injury, spinal cord injury, amputee patients were primarily the patients that were treated by physiatry. We lean more into non-operative orthopedics, so sports medicine and spine care and pain management and a whole bunch of different other conditions that orthopedic surgeons didn't really want to treat, because they want to operate and that's their skill set. So there's a gap in care, and that's where a lot of medical students and young trainees were inspired and decided to pursue this training. So physiatry, we consider ourselves kind of non-operative ortho, non-operative neurosurgery. We do mostly outpatient musculoskeletal care, patients with arthritis and joint pain, patients with spine conditions. Our goal, we consider ourselves the mobility physicians. Mobility is medicine. I've said that so many times on the podcast. Our goal is to make you, the patient or the listener, functional. We want you to play with your kids and grandkids. We want you to play sports on the weekends. We want you to live a high quality life with minimal pain. And just to overall improve your quality of life. And kind of that's what I try to pursue with every patient encounter.
So what inspired you to get into it? I mean, I can understand just based upon how it all started and what it was used for, particularly with the returning soldiers, that there'd be a lot of inspiration there and a lot of great stories that you could tell and help with patients. But what made you specifically, Ricky, interested in this?
So like I mentioned, my dad is an internal medicine physician. So I always knew I wanted to be a doctor, even at a very, very young age. He kind of saw the silver lining in terms of red tape and healthcare. And he said, Ricky, don't be a physician, go into finance, go into banking. And I was good at math. I like numbers. I was supposed to be an actuary when I did one of those personality tests. But despite him leading me towards finance, I said, you know what, I'm going to stick with medicine. So during my senior year of high school, I spent 3 months with an orthopedic surgeon. Our senior year actually ended in March. and we went on something called a Quest project. So I spent 5 days a week with an orthopedic surgeon in the operating room, in the clinic. I love the patients that he saw. I love the care that he delivered. And I said, I want to do orthopedic surgery. So my initial interest was orthopedics. I spent time in undergraduate and medical school doing research in orthopedics. I did not match into orthopedics the first year around. That's something that not a lot of people know about me. So failure is something that I'm not a stranger to. And I spent a year doing research in orthopedics and then matching into general surgery and then eventually getting experience in orthopedic surgery. And what I found as an orthopedic surgery trainee was that, yes, the surgeries were very satisfying. Being in the operating room was great, but I often didn't get that continuity of care with the patient after the surgery. We'd fix a bone, we'd fix the fracture, and I would never see how they functioned 2 to 6 months later. And it was really that disconnect. I loved being in clinic. I loved speaking with the patients and their families and talking about what's preventing them from living the fullest life possible. And at that point, I was in Boston. So the chairman at the time suggested that I pursue physiatry. And to be perfectly honest with you, I had no idea what physiatry was as a second-year resident. So undergraduate, medical school, even the first year of surgery training, I had no idea that this field existed. So I spent 2 weeks at Boston Medical working with the rehabilitation team. And the doctor that I worked with there did outpatient spine care and sports medicine, did procedures, was in the clinic a lot. And I said, this is it. This is what my life needs to look like. I love the kind of relatively stress-free environment. The patients were very, very happy with the care. The doctor was happy. That's the other thing. When I was in surgery, a lot of the physicians weren't thrilled. They were stressed out and they worked a lot of hours, where this doctor was very, very happy coming to work every day. And that's when I made the decision that I'm going to pursue a career in physiatry.
Seemed like surgery could potentially be a lot more assembly line kind of stuff, where you don't see the finished vehicle and what it looks like and how it goes down the road. Sounds like you get to experience the patient experience.
And that's exactly what our multidisciplinary spine center is. We have to have very skilled surgeons, which we have, to do their job. They need to put things back together and take out things when it's needed. And then they need us to kind of prehab the patient, get them ready for optimization of surgery, and then take care of the patients after surgery to restore their function. So I love what I do. I love the people I work with, and it's in a collaborative environment, and I really enjoy the patient encounters. I love seeing patients. I hope they love seeing me, and it kind of gets me through every day.
So what kind of patients do you see now? What is a typical day, a roster of people that come to you?
Yeah, there's no typical day. I think every day is a little bit different. I see young patients who sit at a desk all day, who get back pain, who play sports on the weekends, or weekend warriors who hurt their rotator cuff and shoulder, tossing the ball around with their kids or grandkids. I see elder adults with arthritis, knee, shoulder, hip arthritis, who may or may not end up needing a replacement surgery, but we do whatever we can to either prepare them for that by strengthening the muscles or offering various interventions like stem cell therapy and growth factors or injections. But most of my practice deals with patients with spine issues, whether it's neck pain or lower back pain. And a lot of the patient encounter not only is dealt with what their imaging looks like and what medications and injections I can offer, but really lifestyle modifications that patients can make in their own lives to not need me. It's funny to say that the healthcare business is funny. We get paid to do things. We get paid to see patients who have issues. We don't get paid to make patients not need us, if that makes any sense. Like, preventative medicine is not something that insurance really pays for. They pay for me to wait for you, the patient, to not be active, to gain weight, to decrease muscle strength, to smoke, or whatever it is, and then get an injury and then come talk to us. And I just wasn't satisfied with that. I really wanted part of my patient interaction to be about preventative medicine and preventative care, lifestyle management. And that was also the impetus behind creating this podcast of, what are some strategies that we can all do in our own lives to not need me, not need the healthcare provider.
How cool would it be if you had 1,000 patients that you were responsible for and you got paid by how little they needed you?
And that's a model that we explore. There's a model called the Accountable Care Organization, ACOs. And basically the government's kind of saying, all right, here's a pool of money, take care of this patient and spend what you need to spend, and whatever you don't spend, we'll split. And there's pros and cons there. The pro is that you're going to do whatever is completely necessary. But the con sometimes is you might not do what might be necessary because you're saving money. And so where's that line drawn? And the more we go into quality outcomes instead of revenue outcomes for patients, the better I think we're going to be. And that's a tall ask. that requires change from the top down. And I'm not sure the United States is ready to embrace that type of change in healthcare reimbursements, but I would love to see something along those lines. I should get paid based on how well my patients are living and how little they are requiring in terms of healthcare, but we're not quite there yet.
Not yet. Somebody much brighter than at least me is going to have to push that one down the road. So,
right, exactly.
So tell me what a typical consultation for back or neck pain would be like. What are you looking for? What do you consider? How does it all begin for you with what you say is generally the most common thing that you work with?
Yeah, I would say at this point in my career, most of the patients that I'm seeing in the office have already seen a few other physicians and are coming in for a second or third opinion. So they've had imaging. They've had some of a workup. They might have had some interventions along the way, and they're still not getting better. So that's what I see now. When I first started, it was great because you saw patients who have never seen a doctor before. It was their first episode. They come in without any workup or imaging, and I get to be the person to decide how to figure out what's wrong, how to diagnose and figure out the condition. So for someone with neck pain, the first thing we do is talk about your symptoms. When do they start? Where is it located? What makes it better? What makes it worse? Things like that help kind of guide me in my decision making. And, 9 times out of 10, especially in a place like New York City, where most of the patients want an answer. They don't want go exercise and come talk to me. They want imaging. And we have to really educate the patient on, is an image really necessary? Is an MRI going to change my decision? And I have that conversation, 20 times a day. I was like, yeah, I could get an MRI and I'm probably going to see this. It's not going to change what I do for you. I'm going to tell you to lose weight. I'm going to tell you to build up your core. I might give you an anti-inflammatory medication. And let's see if that does the trick. If it does, we keep it as non-medical, as non-interventional as possible. But if you don't get better, then we'll escalate into maybe injections. Maybe you need surgery and things like that. But majority of the episode and the patient encounter deals with the patient's quality of life. What are the triggers that make it worse? What are some of the habits that we could change? Are you sleeping on time? What does your mattress and pillow look like? How's your diet? In this day and age, we have to see a certain number of patients, right, to meet revenue. It's sad to say that, but I wish I could spend an hour with every patient and really go into every facet of their life that was impacting their spine. Luckily for us at Weill Cornell, we have a center for integrative health, and we really collaborate with them because they can touch on different parts of the patient, whether it's cardiac or GI and sleep and anxiety, and really develop a comprehensive program. And that's how medicine should be. It should be integrated.
Well, you lead me to my next question, because you can't do everything yourself. You can point people in the direction of perhaps right solutions. So how do you incorporate integrative and complementary medicine into what you do? And how do you define those terms?
We recorded a podcast with Dr. Alka Gupta, I think last year, on integrative health. And should we call it alternative medicine or complementary? And I think we're kind of leaning towards more complementary because we have to utilize each other's skill set in optimizing the patient's functional status. You're right. I cannot do this on my own. And I lean on to physical therapists and occupational therapists, the dietitian, nutritionists. All these practitioners and providers are integral in optimizing someone's mobility. We start with what's easy, and what's usually easy is movement. So I try to talk about, what do you do functionally? What does your exercise program look like? And some patients are very, very active. Some patients don't do much at all. So we start with, just take the stairs when you go home. Just walk up and down your hallway a couple of times. I just saw a patient recently who was largely bedbound for 6 months and lost 30 or 40% of her muscle mass. And now she's walking up and down her hallway, which is a huge feat for her. Her weight has come down. The swelling in her legs has increased. And that was it. I mean, every treatment option has to be catered to the right person. And sometimes I need to lean on my integrative specialist or my neurologist or whoever else to really help with the patient care. And I call on my colleagues in that fashion.
You sort of alluded to this a moment ago, and I think I know the answer to it, but I'm going to throw it out there anyway. So much of what you do, like you said, is when things get to a point that's too late. How much do you focus on all the stuff that you can do ahead of time to prevent having to walk through your door? At least when they do walk through your door, how do you work people into that world after that?
You got to really listen to the patient and lean onto what their expectations are. If a patient comes in with back pain and the first thing I talk about is you shouldn't have done XYZ, I'm not going to be very popular. So really it's focusing on what we need to do now to get you out of this crisis. Let's fix the pain. Let's get you into exercise program. Let's use medications and sometimes injections to stop the pain. And I tell patients, the majority of my injections are not cures. An epidural steroid injection is not going to cure you. But if I get rid of your pain or minimize it to the point where you can be more functional, you're going to participate in your rehab program better. So I think the first couple visits are, let's get to know each other. We're still dating. It's our first and second date. Let's see if we even like each other. And let's see if you trust me.
Swipe right, Ricky.
That's
Swipe right. Yeah.
And some patients don't, I've been swiped left before on my first patient interaction, and that happens, and I have to swallow my pride and deal with it. But let's see if we really get along and you agree with my treatment plan. And then let's talk about lifestyle management, like on a third or fourth visit on what are you eating? What are you smoking? Because by then the patient is more comfortable. The acute pain crisis has largely subsided. So let's talk about things that you can do in your life to not need me. And I tell you again, it's a terrible business model for a physician to teach patients what things to do to not come back and see me as a patient. But honestly, that's what motivates me every day, is educating patients to do the right thing and not lean on the healthcare system.
Don't worry. There's enough of us who don't do the right thing that will be knocking on your doors. You had an episode last year that I enjoyed, regenerative medicine. Tell us how you think and feel about regenerative medicine and how you incorporate it into what you do in your practice.
Pain management largely was using cortisone and using steroids. If you see a pain doctor in the community, myself included, we use steroids. That's one of the tools that we have to minimize inflammation, whether it's in a joint, whether it's in the spine, whether you have sciatica. But what we know now, and we've known for a few years, is that steroids is not benign. There are long-term deleterious effects on the body with using cortisone over and over. It causes hair loss. It causes weight gain. It causes bone density loss. But not only that, it can make arthritis worse in the joint. It can make some of the disc degeneration worse in the spine. So we really want to be cautious with using cortisone to treat these conditions. And that's kind of where we're studying and investigating regenerative medicine. Regenerative, it might be the wrong word because, in the lab, we can regenerate tissues in the perfect environment with growth factors. In the human body, we're not really regenerating things, but we're creating the best environment for your body to repair a certain structure. And in the example I often give is with my daughter. She cuts herself, either on the knee, she has a scrape, and within, a day or 2 days, that scrape is completely gone and she has brand new skin. Whereas in an elder adult, someone 60, 70, 80 years old might scrape themselves and get a bruise. It might take them a few months for that bruise to fully go away. And the reason for that is these circulating stem cells in our body, they just get less and less efficient. They used to work very, very fast and very well. And with decades and decades of abuse and use and just being exposed to everything in our world, they get less effective. So regenerative medicine really harnesses the body's own ability to heal. We take blood from the body. We take bone marrow from the body. We could even take adipose and fatty tissues, which has a high quality concentration of some of these mesenchymal stem cells. And we put them back into certain areas, whether it's a joint or whether it's the spine, and create the best environment for the body to heal. And that's really has been my research interest and clinical interest the past few years. We've seen tremendous results with these treatments in hip arthritis and spine degeneration. And we just want to put this tool in the right hands, study it appropriately, and give it to the patients in the best way possible.
Tell us about a very complex case, one that had lots of moving parts here, and the success story that went along with that.
We see easier things. I put that in quotes, such as sciatica, right? Sciatica is relatively easy. Patients usually sit too much or they have a little bit of extra weight in their belly. The disc, the jelly inside that disc can herniate, or people call it slip disc. It pinches a nerve, it goes down the leg, and that's the complaint. We can fix that pretty easily with exercise, sometimes with an injection here and there, assuming they're not weak. Even surgery is typically a home run for those patients because you decompress the nerve and they're functioning the way they'd like to within a few short weeks after surgery. What's more complex is patients who have degenerative scoliosis. And scoliosis basically is development of a curve of the spine. Some patients are born with that, adolescent and pediatric scoliosis. Some patients develop it with time. We all know that we shrink with age. The discs in our spine, which are largely made up of water, they gradually dry out. They were nice, juicy plums, and they're turning into prunes. And what happens with these discs degenerating, if they degenerate in a linear fashion, like one block on top of the other, you won't get scoliosis, but you'll shrink in height. But if they kind of degenerate asymmetrically, you're going to start developing degenerative scoliosis. And these patients are a little more complicated to treat. Sometimes they require a big deformity correction surgery, which again, the surgeons do a tremendous job of making that picture look beautiful. They take a 90-degree S curvature of the spine. They put large rods and screws, and they make it completely 180 degrees, or 0 degrees, I should say, fully vertical. But that doesn't really tell you how the patient's functioning, right? Because you've gone through some muscles, you've made the patient weaker. And that's where we come in and try to employ some of the core strengthening and rehabilitation strategies to, again, restore their function. So the cases I always think about are these scoliotic patients who've seen me, who did therapy, had some injections, didn't get better, went on to this big corrective deformity surgery. Pictures look beautiful, still in pain, come back to see me with more injections. Maybe I refer them to anesthesia pain for advanced pain procedures like a spinal cord stimulator. Refer them to neurology for medical marijuana and other treatments. And that's really the collaborative nature of the patients we see at the Ox Spine Hospital. And one of the best patient stories is someone who had scoliosis who saw all of us and is now playing with their grandkids. And it just gives me joy to see that patient.
The before and after had to be tremendous.
Right.
What are you most excited about when it comes to your field or medicine in general that's coming our way? The regenerative stuff has to be fascinating, and the potential for that be very, very exciting. If you could draw a circle around something, what would it be?
Yeah, I think that's what it is. I think the regenerative orthobiologics, that whole field is growing tremendously. But we want to be cautious, right? We don't want to put the horse before the cart or is it put the cart before the horse and go in the wrong direction. We want to use research and evidence to guide us the right way. And I think regenerative medicine is the perfect specialty to kind of be involved with right now. I love what we do at Weill Cornell with educating patients on lifestyle medicine and optimizing anxiety and mindfulness, diet, nutrition, all these things that hopefully will lead to less healthcare utilization in the future. And that's what excites me. I love working with my colleagues. I love collaborating with other providers who are like-minded. We really care about the patients here. We want them to get better. We want them to live a full and healthy life. And I think regenerative medicine is really going to be part of that process.
So one of the things that you do regularly on your podcast when you're talking to your guests and your experts is, hey, give me some tips, things that you'd recommend for the particular subject that we're discussing, whether it's women's health or for back pain or for your brain, et cetera. So top 5 things that you recommend to your younger patients who are active today and who you want to make sure they stay active for a long time.
I have learned a lot throughout this process of hosting this podcast. Like I mentioned numerous times, I am not the expert. I am simply the person who asks the questions, and I've learned so much from the guests that we've brought on the shows. And one of the topics that comes up over and over and over again, there's actually 2 or 3 topics. One of them is you are what you eat, right? Food is medicine. We really need to do a better job on what we're putting into our bodies. And I need to be a role model for my patients. We talked about a podcast last year where I ate 100 or 200 Egg McMuffins that year that I was in Boston. And yeah, I'm human too, right? I make mistakes and I learn from my lessons, but I mention that because I don't want patients to think that I expect them to completely 180 their diet program. So
just to clarify, the 200 egg, that was a mistake. Just from my own personal research.
Not something I'm completely proud of. Okay, like I said, I'm human, and I did things. I was younger back then, and my body could recover. But you are what you eat is really something that comes up over and over. Trying to limit processed food, trying to limit sugar, eating whole foods, natural, plant-based. I mean, we do that in our family. I'm lucky my wife is on the same page as me with diet. She really pushes me to eat more vegetables and more green. I was largely a meat eater, and with her, we've kind of grown into this eat the rainbow type of diet. So that's super helpful. The other thing is mindfulness. And I think that's something that comes up in New York more than anywhere else. Everyone's stressed out. It's a fast moving city. It's a fantastic city, so much energy, but you really have to take a pause. You have to disconnect, go off the grid, put your phone away. Also something I'm not great at, admittedly. I pick up my phone 100 times a day probably and check something, whether it's an email or a text or social media, but really trying to disconnect and be mindful and de-stress. Stress has deleterious effects on every system in our body, on cardiac, we've heard, on the GI system, on sleep, on weight gain. I mean, think about that. Just you bring stress down in your life, all these systems improve. So that's also something that is super important. And then finally, motion. Motion is medicine, mobility is medicine, doing something in your body, in your weekly routine to stay active. These are the best ways to stay healthy. I mean, small asks. Dr. Mark Lax was on this podcast a little while ago, and he talked about this iceberg in the horizon. And we're all going to hit that iceberg at some point, and that's age and that's aging. But if we can steer our ship a few degrees away right now, with 10 or 20 or 30 years or 40 years to go, we're going to live a much more healthy and fulfilled life. So small changes in your life can make a tremendous difference in the long term.
All right. You talked about the young people, things that you would recommend that they do. You just talked about the iceberg that I am aimed for, and we all are here. So let's change the question. The top things that you recommend to patients who are aging, who want to stay healthy, feeling younger. How is that different from what you share with the young folks?
A lot of it's the same. You can always manipulate your microbiome, right? Your GI can always be manipulated by what you eat. And if that's the case, then there's no time like the present. Let's change some of these bad behaviors that we've had for 60, 70 years of our lives. I feel bad. A lot of the patients that I see who are elder adults, 70, 80 years old, weren't told when they were 20 to stay active. The treatment back then with back pain was bed rest. We prescribed bed rest. Even when I was an intern in medical school, a patient gets admitted to the hospital, one of the first orders we write is bed rest, strict bed rest. And we know that's not the way to do it. You have to move. We get patients out of bed. We want everyone to be active. So those patients were never told this in their 20s and 30s to move. They were inactive. And that has caused age-related disc degeneration and all the sequelae that I treat currently. So moving right now, very important. Staying active with their family, again, kids and grandkids, I think that's going to help them in the long term. Trying to disconnect from technology. You'd be surprised. The patients that I see, 80, 90, very savvy with phones and technology, using WhatsApp and Zoom and all these things, and then eating healthy. Most of the elder adults that I treat eat very well, but just some small changes, staying away from the sugars. I saw a patient, it must have been a couple of years ago, slightly overweight, not really overweight, but just slightly. And we talked about their diet, which was relatively fine. We talked about their activity, which was good. And again, it wasn't until our third meeting where we actually went into what that diet looks like. And she said every night before bed, she eats a bowl of rice because it helps her sleep. And without that bowl of rice, she wouldn't get a good night's rest. So it's very tough for me to convince her that, hey, listen, there's better strategies than eating a bowl full of essentially carbs and sugar to help you sleep, which is obviously going to work, right? You're in a food coma. The blood goes to your gut. It goes out of your brain. You're going to get a good night's rest. But that had deleterious effects on her weight, which led to back pain. So I took small incremental changes in that to slowly phase out of eating rice and doing something else. So we talked about exercise, which she did. And that made a change with her weight, and she was still able to sleep. So again, these small little adjustments in your life can make a world of difference.
So I asked you before what you were most excited about in the world of medicine as a whole. What is something that you're looking forward to in your practice? What type of research are you working on right now that you're excited about?
Most of the things that I treat are degenerative diseases. I hate to say diseases. That there's a condition in the spine called degenerative disc disease. We've largely gotten away from using that term because that's like saying getting white hair is a disease. It's not. It's part of the process of life. It's part of the aging process. So I try not to use the word disc disease, but disc degeneration or joint degeneration. I think that's where we're going to impact the most value, is managing those patients who have undergone some degeneration in their spine, whether it's the joints or whether it's the spine, and keeping these structures healthy. Yes, I think regenerative and stem cell-based therapies are going to be part of that, but really exercise. We know that strengthening the muscles around your spine and around your joints takes the pressure off them. Eating right, decreasing the inflammation in the body through diet, through mindfulness, through stress reduction also leads to less joint degeneration. And we need to really be comprehensive in treating these patients. So, our lifespan 100 years ago used to be 40 or 50 years old. Now our lifespan is 80s, and maybe it's going to be 90s, maybe 110 or 120 one day. So we want all the wheels and the spokes of the body to remain active and healthy, well lubricated. I think we're going to be positioned well to create that.
So what is next for this podcast and for Dr. Ricky Singh and the backstory?
That's a good question. I think I learn a lot from my patients. A lot of them give me ideas on what things they want to hear about. I wish I could tell you that I'm very well organized in what the next 6 months of this podcast looks like in terms of content. You know better than anyone here that I don't have that. I sometimes email you on Friday and said, hey, I like this idea. Let's get this published. But I think just leaning onto patients and listening to what their needs are, and then trying to find an expert who can talk based on the evidence on that topic. So things that have come up recently are like women's health and men's health. I think that comes up a lot. I do want to keep nutrition going with, every few episodes or every couple months, bring on a nutritionist or a dietitian to talk about what's new in diet, how we can maintain a healthy lifestyle. And, you know, I hate to say this, but I do this podcast selfishly. I am learning so much from my guests. I love educating myself, so then I can share that expertise with my patients who maybe don't listen to the podcast. But really, I do this for education, bringing evidence-based to the listeners, teaching me, educating me and my family members on the same. And I ask you guys out there who are listening, give me ideas. You know, tell me what you want to hear about, and I will bring on the experts and develop good content so I can share that back with you guys.
So now we're going to put it out on you listening. What do you want the backstory to be like? What do you want to be next? Maybe it's your story. Maybe you are a patient and you've got an experience and you'd like to share that, or to find out why maybe that experience was so good and offer some hope for some other folks down the line. Let us know. Tell us what you'd like the backstory to be, because when it comes to your back health,
we've got your back.
Thanks for listening to The Backstory. Please subscribe, rate the podcast, and review The Backstory on Apple Podcast, Spotify, and Google Play Music. And feel free to share this podcast on social media or even your own website or blog. This podcast is for general information purposes only. It does not constitute the practice of medicine, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information is at the user's own risk. The content of this podcast is not intended to be a substitute for medical advice. To learn more about Dr. Singh and his clinical research, please follow him on social media. You can also sign up for his newsletter by going to www.rickysinghmd.com. That's RICKYSINGHMD.com.